Good evening and welcome to the Henry Schein Dental Academy webinar series. My name is Corinne and I will be your moderator. We are excited to welcome Phyllis Martina, leading educator, registered dental hygienist, and senior professional education manager for Colgate Oral Pharmaceuticals as our speaker tonight for a deep dive into proven strategies to enhance patient education conversations. Before we get started, we do have a few reminders for you. At any point during the webinar, if you have questions, please type them into the Q&A section of your control panel, and we will answer them live at the end. Henry Schein is not offering CE credit for viewing or attending this presentation, live or on demand, and this webinar is sponsored by Colgate. Phyllis, welcome and thank you for being with us.
Thank you so much, Corinne. So tonight we're going to talk a little bit, just for the next hour, about strategies to modify patient behavior and boost patients' adherence to your recommendations. It's something that can help make your life and your practice much more comfortable and welcoming for your patients. So let's just dive in. So first we have a quiz, fact or fiction, and I'll give you a minute to look at the questions and then come up with your response. So Corinne, how are we doing with the responses?
All right, it looks like 81% said all of my dental patients and 19% said November 1914.
So the fiction is all my dental patients follow my recommendations. So for 90% of you, that's true as well. That you wish, I bet you wish that percentage was higher. But it's true that most patients don't follow our recommendations. So why doesn't everybody follow our recommendations? We're smart. We went to school a long time. We learned a lot of stuff. We are the experts in our field and we have our patients' best treatment in mind. So why don't they? What's that carrot we can offer our patients to make them follow what we want them to do for their benefit, their health? Well, how do we find health? Let's back up and talk a little bit about health in general. How do we define health? And if you think of one word answers that you may say of what health is, it's more than just the absence of disease. It's strength. It's being in the pink. It's being robust, with vigor, being in shape. Used to be that health was defined as I'm not sick, I don't have any disease, but now health is so much more. It involves more than just our physical body, involves our emotional well-being as well. In 2000, the Surgeon General's report looking at oral health in America said oral health is integral to general health, and that the mouth was a mirror of the physical health of the body. It was a warning system, a sentinel for other diseases that could be happening in the body. And if you're not familiar with the phrase canary in the coal mine, the mouth is kind of like the canary in the coal mine. And that phrase came about because coal miners worked in with not toxic gases in the coal mines. So they would bring canaries in with them in cages. And because of the canary's fragile pulmonary system, if there were toxic gases in the coal mine, the canaries would die. And that was the signal to the miners to evacuate that coal mine, that something was wrong in the coal mine. And so our oral health, the oral cavity, is actually the canary in the coal mine. A lot of times, if things aren't healthy in the mouth, it may mean that there's something else going on in the body. And that's what the 2000 Surgeon General's report outlined to the population. And this was well known and well studied and well developed with diabetes as a two-way street. Poorly controlled glycemic index increases the risk for periodontitis. And periodontal disease can make it difficult to have glycemic control. So you need to do both. You need to take care of the diabetic patient with insulin and diet and whatever else is recommended by the endocrinologist, But you also need to control the biofilm and the disease state in the mouth to have a good balance of physical health and oral health. 2021, just last year, the Surgeon General's report just reiterated that the mouth is a gateway to the rest of the body. And it talked about oral diseases are common, but not only does it affect the mouth, it affects their it affects more illness and earlier than normal death. So the oral cavity is again a gateway to the rest of the body. It also talked about impaired oral function impacting the social and emotional well-being of our patients. So it's not just the mouth, it's not just the body, it has the whole patient we have to be concerned with when we take care of our patients. And we know good oral health is responsible for the ability to taste and to chew and swallow and speak, but it's also the ability to smile, to express. And you've been around people that either don't laugh, or when they laugh, they cover their mouth, they don't smile much, or if something makes them smile, they cover their mouth because something in their mouth is preventing them from showing their teeth. So we are responsible for not only taking care of the oral cavity and the physical well-being, but the emotional well-being of our patients. And the impact has been proven in our physical, with the oral health, with the physical health. And this was a study by United Concordia, an insurance company where they have dental coverage as well as physical coverage. And the patients, all they needed to do was go in for their semi-annual checkups and prophylaxis. And you can see that there was phenomenal savings, not only for the insurance company, but obviously to the patient, in that they didn't have hospitalizations, they didn't have added medications, they didn't have added appointments to their physicians to treat these conditions, and they monetized it. $3,291 for diabetes, almost $4,000 for arthritis, $3,000 for heart disease. So this proves that what we do in our dental office with our patients to take care of them, to prevent other diseases, has an impact not only on their oral care, but on their physical health and on their emotional well-being. But despite what we know, still half the population in the US has gum disease, as well as caries continues to develop throughout every age bracket that we have, despite the fact that it is 100% preventable disease. We still have caries as well as we still have gum disease. So the facts are that caries, periodontal disease, and tooth loss affects almost half the population. And the interesting thing is, despite all the research, all the changes that we've undergone, everything we know, that this burden has remained the same for the last 25 years. There's hardly anything that stayed the same, even for the last 3 years, let alone 25 years. But the rate of dental disease has stayed the same. And untreated decay is one of the most widespread global health condition and affecting 1 in 3 people worldwide. So we've got a lot of work still to do to take care of our patients and the population. We know the cause. The cause in most cases is biofilm. It's biofilm that builds up on the teeth, and there's diet and certainly other things that can affect it, but mostly it's biofilm. And we know the solution. It's home care, good care in a dental office, a good diet that can take care of it. But how do we make our patients care as much about their oral health, taking care of their home care, doing the treatment plans that you outline and recommend for them? How do we make them care as much as you care? Well, one thing that we can do is communicate differently with our patients. We do our assessments for periodontal disease, caries, cancer, all these conditions. And we use different diagnostic tools, our exams, x-rays. But let's look at risk assessments. A lot of you are doing risk assessments. If you're not putting it on paper, you're at least doing it as part of your treatment planning protocols. But let's look at a way to do it that we can help communicate with our patients a little differently, that engages them more and helps them ask us questions and get more involved in the treatment. First, let's talk about gingival and periodontal diseases. Well, in 2017, the AAP and the European Federation of Periodontology got together to reclassify periodontal disease. And they wanted to look at a way to make it a little more objective so it would be uniform between practitioner and practitioner. And this was to help diagnosis, help define the treatment, and definitely research, but also communication. Communication between healthcare professionals, between dentists and specialists, as well as between dentists and physicians, but also to help that communication with the patient. And if you look at some of the things they changed it, and this is just a little smattering. If you go to the Perio site, there's a huge book that you can read all about this. Do this tonight after the program's over. But it added stages and grades for periodontal disease. And stages are based on the severity and management complexity of the disease. And grades are the risk progression, or excuse me, the progression of the disease, which talks about the risk. And there are these wonderful handouts that you can get. You go online to perio.org, you can pull this up. This tells you how to stage that patient. When you look at them and look at clinical attachment loss, radiographic bone loss, what stage does that fit in? And when you think of stages as it relates to healthcare, you obviously come and think of, well, that relates to cancer. Unfortunately, cancer has become quite common, and people always ask, what stage is it? Because we know if it's stage 1, it's very early onset. There's a lot of treatment we can do, versus stage 4, which adds more urgency to the treatment and more complexity to the treatment. So when you're doing your assessments, if you're using staging, you can communicate to the patient what stage they're at. And most people will know, wait a minute, I know what stages mean. I know stage 4 is the most progressed, that I have the highest level of disease, whereas stage 1 is the least. And then you talk about grading, and grading talks about the rate of progression. And you can look at the criteria again, go online and pick up these. You can take these, laminate them, put them chair side so that you can refer to them. But it talks about the rate of progression. So A is very slow progressing. And tell somebody they have a grade A, they know that's good. They went to school. Everybody went to school, at least at one point. And if you have a grade C, that's not so good. So if you tell somebody you have a stage 3 grade C, rapidly progressing periodontitis, you know that they're going to take that as more impactful on what they may need to do for their treatment. So as you go through your treatment planning and tell the patient the stage and grade and what it's based on, you're able to communicate to them the severity and the urgency of treatment for their disease state. Now let's talk about caries. So you've probably seen something like this. This is the caries progression. And you see with the green, that's very positive. It's a lot of protective factors with caries. So a lot of saliva or sealants, antibacterial toothpaste and mouth rinses that the patient's using. Do they live in a fluoridated area or using extra fluoride in their diet somehow? And do they have an effective diet? Or are they a big energy drink person and have a lot of sodas? And then risk factors. It's yellow. It's just like the traffic signal. A lot of biofilm on the teeth. There may not be good salivary flow, and they have a poor diet. They eat a lot of sweets, a lot of refined carbohydrates, or they're sipping on sweetened tea or something all day long. And obviously, red, they've got active disease. They've got white spots. They've had restorations. And they currently have cavitated lesions that are either into the enamel or they're cavitated into the dentin. So they already have disease. Putting it in that green, yellow, and red helps you communicate with the patient. And this is the ADA risk assessment form. And the reason I like it is because it is color coded. You can give this to the patient, they can mark it off, and they can see if they have anything in this red column, they're at high risk for caries. If they have any check, any of those conditions in the yellow column, they're at moderate risk, or they're at low risk if all their checks are in the green column. But if you have those columns color coded, patients know what green, yellow, and red mean. And so if they mark it and you say you're at high risk for more caries, it can give that patient the feeling that, wait, I don't want to be at high risk. I don't want to get cavities. I don't want to get that. What can you do to help me not get those cavities? And it just facilitates that conversation if the patient sees that they're at high risk. So if you're doing a risk assessment in your head, which a lot of people do, they look at it, think about adding something to give that patient some kind of a physical, visual representation of the amount of risk they have. So obviously, if they're low risk, a fluoride over-the-counter toothpaste and maybe an over-the-counter mouth rinse may be help for them to keep them at low risk. If they're at moderate risk, you will want to prescribe a 5,000 parts per million fluoride and possibly a 900 parts per million rinse. Both are prescription. However, we know that about 50% of prescriptions never get filled. So if you want to, you can supply these things and dispense them from your office to make sure that the patient actually gets the toothpaste, the high fluoride toothpaste that they can use that night. You can just dispense it in your office. There are ways to manage it as far as charging the patient for them. But then you know at least your patient's going to have the product that you recommend to help lower their chances of getting more caries. And then if they're at high risk, a varnish treatment in the office is recommended, along with the home fluorides, the 5,000 parts per million fluoride. But if you've done that risk assessment where they've marked off and they've seen themselves in the red column, it may be easier to tell them, I recommend a varnish treatment, a fluoride varnish treatment in the chair today. And your insurance doesn't pay for it, but you're at high risk for caries, and this will help reduce your risk for caries. Is it okay if we give you that treatment? They're much more likely, if they've seen that they're at high risk, to accept that. So we have another poll to talk about. What do we recommend? We recommend brush, floss, interdental aids, but what is the average time patients spend brushing at home? And I know we recommend interdental cleaning most often with flossing. What percentage of patients floss regularly? And I'll wait a minute to give you time to think about it. I'm sure it's very complex. Okay, Corinne?
All right, this one was a close poll. It looks like for the first question, 40% said the average time spent brushing was 46 seconds. And for the second question, we had 43% of people say 11 to 18% of patients floss regularly.
Okay, thanks. Well, very good on the first one. The average time spent brushing is 46 seconds. But what percentage of patients floss regularly? It's only 2 to 10%. And most patients cannot or will not floss on a daily basis. And I knew when I was doing clinical practice, patients would come in and they would floss maybe a week to 2 weeks before they came in. So things looked good. But they didn't floss after that until their next appointment. The funniest patient I had, he said, you know that dental floss? That lasts forever. You never have to buy a second thing of dental floss. And I just looked at him and I said, well, if you use it every day, you do. But that meant he flossed only right before he came in to see me. So things look good. But we do need to talk to our patients about cleaning interdentally. And for brushing, the time spent isn't as important as making sure they cover their full mouth. And you can't cover every single area of your mouth in just 46 seconds. So we need to lengthen that just by a bit. So when we talk about brushing, manual versus power, and people have opinions one way or the other, but 86% of the population use a manual toothbrush still. And of that 86%, 62 are not interested in using power brushes. So for those other patients, the other 15% that want to use a power brush, great. That's great for them. But most people are still interested in using a manual brush. So you need to keep that in mind as you're talking to your patient about their home care recommendations. But power brushes do have a benefit. One of the things they have is patients they can see visually areas they've missed on their mouth because they're connected to our smartphones, different apps. And you can see that the patient missed this lower right section, just on the buccal section. But they're pretty good brushers. They got 80% coverage and way above average on brushed for a minute and 48 seconds. But power brushes can add to what a patient does at home, and especially ortho patients, where it's really challenging to brush around the brackets and the bands that they may have. And it actually gives games so that people can earn badges, they can earn points, they can get free products. So I believe that some people are going to switch to power brushing as it becomes more fun for patients to brush. But just keep the manual brush in the back of your mind with your patients. And then interdental cleaning. We say floss, but 2 to 10% of people are willing to floss on a daily basis. And we do have interdental brushes, but they don't work for everybody. Some people have such tight contacts and close interproximal spaces that an interdental brush just isn't going to work. Now, these floss picks, somebody's using those because anytime you go into any parking lot in the United States, you can find several of these on the parking lot surface. So I don't know whether I should be very happy that at least people are flossing with these picks, or should I be very concerned that people are flossing while they're driving? Not sure where I sit on that, but I know somebody's using them. And then there's water flossers, and water flossers are certainly a valuable adjunct treatment. They do require some education and some time commitment from the patient, but the patients that use it really love them. What about mouth rinses? Well, we know they're very easy to use. If people have dexterity issues, they have malocclusion, a lot of overlapping teeth, it can help get into those hard to reach areas. And the more complex the restorations are, the more it can help remove some of the biofilm and take care of some of the other issues that patients with a lot of complex restorations may have. If you're recommending a rinse, have your patients use a therapeutic rinse. And they're therapeutic because of the active ingredients. Chlorhexidine is obviously one of the most highly regarded oral rinses. It is prescription only. The one advice I'd give you with if they're using a chlorhexidine rinse is tell the patients not to rinse with anything after they rinse with chlorhexidine, because the first thing that goes away is the flavoring agent. And it isn't the most pleasant tasting mouthwash. But chlorhexidine rinses are recommended just for a short period of time, 2 to 3 weeks, because they do have the staining as well as increased calculus formation if they use it too long. Peroxide is a great rinse. It certainly helps with people with a lot of aphthous ulcers, people that may have other mouth sores, even pizza burns. It helps keep those lesions clean so that they heal well. Essential oils are very well studied as being effective against biofilm, as well as CPC, cetylpyridinium chloride. That's in over-the-counter rinses that patients can use. And if a patient is at moderate to high risk, a sodium fluoride rinse is recommended. And that can help reduce their caries rate. And then toothpaste. I love toothpaste. Toothpaste matters, and it's often overlooked as an active ingredient, an active aspect of home care. And one thing we need to look at is what we're recommending the toothpaste for and what we're trying to work with in that patient. It's not just a breath freshener, it's not just removing some extrinsic stain. But if you're using it for gingivitis, caries, dentin hypersensitivity, any of those other conditions, you want your patient to really use a full brush head of toothpaste. The studies that have been done that talk about the benefits of toothpaste all use about a full brush head of toothpaste. We're going to talk a little bit more about that in a minute. So when you're looking at different toothpaste, there's a lot of different ingredients to make it palatable for patients, to make it come out of the tube easily, to make it taste good so people use it. But we're going to talk about the active ingredients. The active ingredients will tell you when to recommend what kind of toothpaste for your patients. So one of the active ingredients is hydrogen peroxide. So people want whitening toothpaste. A lot of times it's just a different abrasive agent that's in that toothpaste that will help remove extrinsic stain from the teeth. But peroxide is an actual bleaching agent, and it is in over-the-counter toothpaste that you can purchase, and that actually will help whiten teeth. You do have to use it twice a day, every day, to get the best benefit. Potassium nitrate can depolarize the nerve in the dentin tubule. The thing with potassium nitrate toothpaste is you have to saturate the saliva with the potassium ion. And to do that, you have to use a full brush head of toothpaste twice a day, every day. If patients don't do that, they won't saturate the saliva, and that potassium ion won't get into the dentin tubule to help give them that sensitivity relief. A lot of time what patients will do is they'll use a normal toothpaste in the morning and their sensitivity toothpaste at night because they don't like the taste. So find a toothpaste that you think tastes the best. And give them some options and tell them to use it every day, twice a day, a full brush head. And within a week, they should notice some sensitivity relief and very profound sensitivity relief in 2 weeks. Once they stop using it, though, the potassium ion goes away and they may get sensitivity back. So have them keep it up. Arginine, especially when combined with calcium carbonate, blocks the dentin tubules. And there isn't a toothpaste in the US that has arginine. There is the Colgate sensitivity serum, which is a small tube that you can apply in the office that has arginine and calcium carbonate, and it actually blocks the dentin tubes. But you can apply it in the office so you can go about your procedures, the patient can be comfortable, and then you give the tube to the patient so that they can go out and have ice cream, and they actually apply it to the tooth or teeth that are sensitive, or if they want to go out and have cold drinks or go skiing or whatever they're doing, whatever causes the sensitivity in their teeth, they have control and they can apply it at home. And then fluorides are great for remineralization. We have monofluorophosphate fluoride, sodium fluoride, and stannous fluoride. Stannous fluoride is well known, well studied, has been around for years. It's older than me. And it does have the anti-caries properties from the fluoride, but it also has anti-gingivitis and anti-sensitivity from the stannous. But stannous fluoride is very difficult to formulate in toothpaste. And the reason is stannous fluoride is active and can work against gingivitis as well as sensitivity. But the minute it contacts water and air, it oxidizes and becomes stannic stannic, and that is inactive. So I bet you can't guess what the main ingredient in most toothpaste is. It's water. So how do you formulate a toothpaste with water in it and keep that stannous active? Well, you combine it with a zinc phosphate ion, and that helps stabilize the stannous fluoride ion. So you get the benefit of the fluoride as well as the anti-gingivitis and anti-sensitivity benefit of the stannous as well. Not only does the stannous fluoride with zinc phosphate work on the teeth, but it also works to lower the bile burden on those reservoirs of bile burden in the oral cavity. We know about the tongue. You may recommend to the patient that they use a tongue cleaner or keep their tongue clean. But this toothpaste also works to lower the bile burden on the tongue, the cheeks, the gums, and the saliva, lowering the bile burden in the entire oral cavity for whole mouth health. So now we've used our assessment tools. We've talked about the stage and grades of periodontal disease. You've relayed that to the patient. They looked at the color-coded risk assessment form for caries, and they see they're at moderate or high risk of caries. You've talked about home care routines and things that you want to recommend, or you've developed those in your mind, as well as a treatment plan. They need to come in and get some restorations replaced. That they need to come in every 3 months rather than every 6 months, that maybe they need some periodontal surgery. You've thought about all of that. So now we brought the horse to the water. How do we make them drink? So this might be something you'd say to your patient. You have inflammation on the upper right and should brush and floss. Brush with a soft bristled toothbrush and use an antibacterial paste twice a day for 2 minutes and floss once a day. And you've said that to your patient. It's very easy. It's pretty standard, right? Here's what your patient may hear. Floss, everything looks good. Floss, brush, floss, floss, floss. That's not at all what you said, but that's maybe what they remember when they get home. So now we're going to have a little play, the dental appointment, a play in 3 acts. And it only takes 3 actors. We want somebody to play the dental professional, somebody to play the patient, and somebody to play time. So here's the first act. The setting is your dental office. The patient's in the chair and you're standing facing the patient. And you say again something like this. You have 1 cavity. Your gums are swollen and bleeding. You have an infection in your mouth. Good brushing and flossing are always the best ways to take care of it. Also, use an antibacterial mouthwash and toothpaste. Flossing is easy to remember to do if you remember to do it. So remember, don't forget and brush your teeth twice a day for 2 minutes and floss once a day. That's all you need to do. Got it? Well, the patient looks at you, smiles, says, oh, okay, thanks. See you in 6 months. The patient gets out of the chair and they leave. And then time happens. 6 months later, you come back, the setting's your dental office, and it looks vaguely familiar. The patient never got that restoration. Their gums are still swollen and bleeding. And so you go through the whole routine again, right? You say, got it to the patient? They say, yes, I have it. Thank you very much. I'll see you in 6 months. 6 months go by, and what do you think happens? Same thing over again. Well, thank you very much. We applaud our actors. And I'm sure this doesn't happen to you with every patient, but it does happen sometimes. Or sometimes you go in the next time you see the patient and you say, hey, did you get that water flosser I recommended? And they say, you never recommended a water flosser. For some reason, our messages aren't sticking with our patients. They're not remembering them when they get home. They don't follow our recommendations. So how do we make it so the patient remembers and is involved with our recommendations? Well, this is an image of a focus group. And if you've ever been part of a focus group, you kind of know what happens. But if you haven't, there's a group of people here being asked specific questions. It could be about habits they have at home, products whatever the people are interested in learning about, the researchers. This is a moderator who's asking questions and taking notes. And this is not a window, it's a one-way mirror. The participants on this side see themselves, it's a mirror, but there are people on this side that are very interested in hearing about these people, what they do at home, what products they buy, what they use, how they feel about different things. Focus groups are used a lot in different kinds of research. And you can see there's snacks and drinks on both sides. So what we did is we brought a group of hygienists in and asked them questions about oral care recommendations they make to their patients. Then we took those hygienists, walked them outside along the hallway and back behind the one-way mirror. And then on this side, we brought in patients and asked them about their hygienist recommendations, what the hygienist said, what they did at home, what they remembered, and what they followed up with. And so to find out what they said, well, the hygienist said they always give oral hygiene instruction with very specific recommendations for each patient. They ask the patient to hold a mouth mirror so that they can point out in the mouth the areas that may need more care, what they're seeing, like is there some inflammation? They might even take a barial probe and say, see, this is a 6. This needs extra care. And they are 100,000 million% convinced their patients know exactly what they're talking about, remember what they say, and act on it at home. 100%. Then we did the revolution. We brought the hygienist back and asked the patients about their appointments. So my hygienist talks all through the appointment. She shows me in the mirror, but I can't see what she or he is pointing to. And I don't remember what she says when I get home. All I remember is to floss. Was this surprising? And hygienists were awestruck. They just couldn't believe it. And what are some of the barriers? Well, from the patient side, they think they pay their money to come in and you take care of them. They don't have to do it at home. That's why they come to the dental office, for you to take care of it. They're too busy. It's too hard. And why should I care? They're just teeth. They're going to be there. It's no big deal. And for the dental professional on the other side, there are barriers sometimes too to going into it again. I don't have time. I don't have time to spend a lot on oral hygiene instruction and going through this again and again. And especially now that our infection control procedures are taking more and more of our time. Something's got to give. And it won't make me look more professional. They won't like me much. They come to get their teeth cleaned, I say, with the air quotes. So why do it? And my patient's behavior doesn't change. They come back still the same way because I've seen the play, a dental office play in 3 acts. And some people are worried about that nagging. Remember that old feeling that the dentists and hygienists say the same thing over again, and they just nag, and their patients will like me less. And we do want our patients to come back, and we do like them, and we do care about them. So how do we fight those barriers? How do we get over those barriers so that we can get them to accept our recommendation? Well, we ask patients, why don't you follow home care instructions? Some patients say they feel vulnerable lying on your back. And especially if you're doing oral hygiene instructions, or you're making your recommendations, or you're talking to the patient about what restorative treatment they need with sharp, pointy things in their mouth. If they feel vulnerable, they're going to be a little defensive. They're not going to listen as well. They're not going to hear you as well as if they're sitting up and you're sitting up talking to them. If they feel vulnerable, they're not going to absorb that information that you're giving to them. I can't see or ask questions while she or he is working. And some people have questions. They may even forget them by the time the appointment's over. And you're ready to ask them, well, do you have any questions for me? They may not remember them, or they don't want to appear stupid, so they don't ask any further questions. And when they get home, I know I've said this before, but when I get home, all I remember is to floss. They don't remember what you said about some fluoride toothpaste to use, or how to use a rinse, or how to use that water floss or something different. They don't remember because they've got a lot of things going on in their life too. And then there's that patient with the attitude. I come for you to do the cleaning, not to hear about what I should do at home. I pay you good money. You take care of it. And I'm sure you can think of at least one patient that's had that attitude. And then we know that everybody learns differently. Some people are just not going to learn from hearing it. They need to see a picture. They need to read it. They have to have it in multiple ways for it to set in. So those are the kind of things we're looking at with our patients. So how do we go from speak no evil, see no evil, hear no evil to motivation? Well, we have to look at our defense mechanism, which is denial. We don't want to hear what we don't believe. And that's true for us. It's true for our patients. So some people believe that they're better than everybody else. They have a self-positivity bias. I'm better than everybody else. I'm smarter, I'm faster, I'm better, I'm healthier. Bad things are going to happen to other people or not me. And that prevents them from listening and hearing what you have to say. And a lot of people ignore concepts outside their beliefs and values. They ignore negative information. So if you tell them something that doesn't fit with their beliefs and values, they're not going to pay attention. And they say, if it's going to happen anyway, what can I do? You know, I know my mother, my grandmother, and my grandfather and father all lost their teeth. You know, why should I do this? It's going to happen anyway. What can I do? So values. You don't tap into somebody's values, you're not going to be able to change their behavior, because values influence behavior. And values develop through the application of knowledge, not knowledge alone, but the application of knowledge. They're not neutral, they're held with strong personal feelings. And you can tell when you challenge somebody's value system, they'll get defensive. They may not say anything, but you can hear it, or you can see it, excuse me. You can see it. They might look back, they might turn their head away, they might narrow their eyes a little bit. But once you butt up against their value system, and they start to go into denial, your ability to change their behavior is going to be very difficult. They're going to be very resistant. And one very clear example is smoking. We know smoking is bad for us. Everybody knows it. Yet so many people still smoke. And especially with vaping, we know a lot of people vape. They believe it's healthier, even though there's evidence out there that says, no, it's not healthier. And it's written right on the package that it's going to cause lung cancer, heart disease, all these things, because information alone does not change behavior. If you don't tap into somebody's value system, find out what's important to them, and then use that application of knowledge into their value system to change their behavior, they're not going to change behavior. You may have heard about motivational interviewing, and it's a conversation style where you talk to the patient, find out their value system, find out what's important to them, and get their own commitment to change. And it's a full course. I'm not going to go into it in depth here. But if you're looking for courses, looking for somebody that has this Mint logo, Motivational Interviewing Network of Trainers, they have a whole website that you can go to. But these are people that do like we do with CPR. They take courses all the time and they get recertified. In traditional patient education, and if you went to school when I did, you're the expert, you give advice, you give information. It's usually a one-way conversation. But when you use motivational interviewing, rather than it being you will do what I do because I'm the expert, it's more like a dance. You ask them a question, they respond, you move one way, you both work together to find a solution and something that will work for them as well. You do it through these 4 steps: engaging, focusing, evoking, and planning. Engaging is where you talk to the patient and you ask them, you know, you're here today. What would you like? What would you like to make sure I take care of for you? Not only today, but throughout our whole relationship as a patient and a dentist. Why do you keep coming here? What's important to you? If somebody says, I want to stay out of pain, I'm afraid of pain. I don't like coming here, but I don't like pain. Focus then on that value. They don't want to have pain. So you don't want to have pain. What concerns you? Well, you know, I don't want to have a root canal. I don't like to have fillings. It just makes me very uncomfortable. Talk to the patient about that and say, okay, let's talk about that. Let's get to your motivation for change. That's the evoking part. So I'm with you to work on it. I don't want you to have a root canal either. And in fact, many of my patients don't have root canals. And we can work together to keep any restorations to a minimum when they're very easy to take care of, when they're not likely to cause you pain. Can I give you some information that I think can help you achieve that? And then work with the patient. That's where you get together and give them the information once they've given you permission to give that information. And then the planning with the patient. So you agree you'll come in every 3 months or whatever it is and outline it. But in the planning stage, you want the patient to say what they're doing. Once they start saying it, then they're more committed. They're more likely to remember and more likely to do it. And some people say, well, you know, motivational interviewing may not work, but there are studies that talk about just even a 1-minute conversation can have significant changes in behavior. And if you use motivational interviewing with mothers, it can reduce caries. And it's been successful as a counseling technique in alcohol abuse, tobacco cessation, and aggressive behavior, domestic abuse. And even the ADA has a CDT code for motivational interviewing that you can use. So let's talk about our patients and their activity in their house. How actively are they involved in their health? Well, they know their numbers. They know cholesterol. They may know their BMI. They set goals for themselves using, you know, smartwatches and other activity trackers about how much they're walking, how many steps do they have, what their blood pressure is, what their heart rate is. And a lot of people are adopting more healthy habits. So the internet is a diagnostic tool, which is a blessing and a curse a little bit. So over 50% of adults have looked online for information. And they say they've used the internet to try to diagnose their condition. They're online diagnosers. And as healthcare providers, we say they went to Dr. Google, and it's usually not a positive thing. Many of the online diagnosers talk to their healthcare provider about what they found online. And the amazing part is 41% of them are correct. That means about 60% are correct, but 41% are correct. So instead of looking at Dr. Google as our foe, let's consider Dr. Google our friend and help use Dr. Google to help us have meaningful conversations with our patients. This is a new online test, a tool that's been launched to help understand what patients know about their oral health and how their oral health impacts their general health. And you can see there's a place here to take a quiz and you can brush up on the facts. So the quiz, 10 very easy questions. They'd be easy for you and me, although I know some of my colleagues have not gotten a 10 out of 10, but I'm sure you would. But what are the signs and symptoms of oral disease? And you can see spitting blood when brushing or flossing. Well, a lot of people think that's normal, but the correct answer here is all of the above. It will let them know that spitting blood when they brush or floss is not normal. And it gives them some additional information that they can look at, and they can come to you and ask more questions. Hey, I took this quiz online that you recommended, and it said that bleeding when you brush your teeth isn't healthy. My gums bleed all the time when I brush my teeth. And they can also go online and get some additional facts. For those people that need to read and need to see something else, this can be a very beneficial tool for them. And then there's also the Gum Health Physical. This helps start that conversation with the patient as well. If you just Google Gum Health Physical, you'll come to a site that'll have a blank arch depiction of the mouth, just like this. And you can go in and with your patient, you can mark in red the areas that you think the patient needs to pay more attention to. And then when you sit them up at the end and they can see this graphic depiction and say, wait, all my lower front teeth are red. Why are they all red? And you can have that conversation with the patient and then ask them, what are you willing to do at home? Using some motivational interviewing techniques. What are you willing to do at home to change those from red teeth to white teeth again? And get them involved in their treatment. So another online tool that you can use to make Dr. Google your friend, not your foe. So when you go and see your patients tomorrow, there's a few tools that you can use. In your diagnosis, look at the risk assessment tools. Look at risk assessment tools that help you communicate with your patients in ways that are understandable to them. Use home care treatments that are beneficial. And because you've used those risk assessments that they can see and know they're at high risk for caries, that they're more likely to pay attention to. Have that conversation with the patient where you engage them, find out their value system, find out what's most important to them, and tie that back to their home care. Remember, you're in it for the long haul with them. You want to create a relationship. So start off with baby steps, something easy if they need a lot of help, and then gradually work them into it to get that patient agreement so they will do what they can at home. Get more to yes and get more to a collaborative conversation with your patients. I hope this has been somewhat helpful. I hope you take at least a few nuggets that you can use tomorrow when you're seeing your patients. Thank you very much for your time. And thank you on behalf of Henry Schein. And Corinne, do we have any questions?
We do. So thank you. If anyone does have any questions, you can just put them in the Q&A section of your control panel. We have a question from April. This was earlier on in the presentation. She asked, do you use the worst tooth or an overview of the mouth to make a diagnosis?
I'm thinking this is for staging and grading.
I believe it was, yes.
Okay. So in the instructions from the AAP, they want you to use the worst tooth, the most diseased tooth. So you pick that tooth. And again, go to the AAP website. There is a huge book, but those staging and grading sites, they have a lot of different easy tools to look at to help make it easier to make that diagnosis and that staging and grading. But you do use the word and you do add other factors in it. I went through very quickly. You look at if they're diabetic, if they're smokers, that can all add into that. I just went through it quickly with the resources so that you could look online and get more information. Thank you. April?
Perfect. Thank you. We did have Martha ask if we can have access to the recording. Yes, it will be sent out. She said she needs to listen to this multiple times. And she also asked, how do you approach patients who don't value primary teeth?
So I would ask them more about why they don't value primary teeth. What are their thoughts about it? What do they know? What's been their experience? And they may give you some misinformation. It doesn't matter because the teeth fall out anyway. Then you can say, oh, well, if the primary teeth did have effect on the permanent teeth come in, would that make a difference to you? If it did affect the arch shape or it did affect the permanent teeth coming in, would that have any effect on you? Would it change what you think a little bit? Before you start giving in information, ask them questions. And if they say, well, yeah, it might, just say, well, I do have some information on that. Can I share it with you? Always ask them permission, get them to verbalize yes, and then go into how the primary teeth do affect the position, placement, and health of the permanent teeth as well as the arch. You can go into that. Don't give more information than the patient's ready to absorb. Keep checking in and asking, what do you think about that? Does that change anything that you're doing? And just keep getting to what they value the most. Next question.
Perfect. Thank you. We actually do not have any more questions. We're just getting a lot of thank yous.
Oh, good. Thank you.
Michelle says motivational interviewing is the best thing that she learned as a dental hygienist. So it's definitely doing well. So thank you, Phyllis, for the great presentation. This was great.
Well, thank you very much. And thank you, everybody, for your President's Day evening. And have a great day tomorrow. Thank you.
All right. Thank you again, Phyllis. And thank you, Colgate, for sponsoring this webinar. If anyone does have any outstanding questions, please email us at webinars@henryschein.com. To view and register for upcoming webinars, go to henryschein.dental.com/webinars. And as a thank you for attending, everyone will receive the recording via email in the next week. So thank you all for joining us, and we look forward to seeing you on future webinars. Bye, everyone.
Bye-bye.